are you've already got a lot of knowledge, so the basic stuff I guess you already have. So I like to discuss some things on the first web and syndactylies, if you're okay, because that's I think the bulk of the stuff you do. We already discussed a bit of polydactyly a long time ago, so that I thought that would not be that necessary. Now I'm going to try to share my presentation. And I was a bit struggling with everything today, so I hope I can find it. Probably it's in more or not, or how do I share the presentation I made? Yeah, got it. I have to, this is, I'm going to try it again because it now says I have to end my, the Zoom app before I can share something. I'm going to try it again. Hopefully it's working now. Can you see it now?
Yeah, we can see it. Thank you.
Perfect.
We
Well,
don't see it full screen though, Christiane. Yeah, now it's
if
full
you see it
screen.
now, yeah,
Yep.
perfect.
Yeah.
I already had it full screen, so I was completely ready to go, but obviously Zoom doesn't accept that. So a little bit of congenital hand, because, if you want me to talk about congenital hand, I can talk all day or a week or whatever. But I can do, so that would be boring to do it a whole day. And just a short introduction. We've got a big team of congenital hand surgeons, rehab doctors, hand therapists. We've got 3 hand therapists. We've got specialized plaster masters, we call them, to help us treat the children. So what we do is we see children with a big team, and we see cases like this, for instance. And this is actually a little bit of the things I saw today, except for the cleft hand. I didn't see that one today, but the rest is quite a normal outpatient clinic. So why do extremities especially go wrong? Except for more than you see other congenital anomalies, you see most congenital anomalies are in the arms and a bit and also in the legs, but less than in the arms. And actually, it's because the development of the arms and the legs is very complex. And the other thing, of course, is that you don't need it to survive. So if you have a severe heart condition or a severe brain condition, the fetus won't survive, but with a severe arm condition, the baby will survive and be born. So, and if you want to read something about that, this is a very interesting book by Armand Marie Leroy. It's called Mutants, and one of the phrases he starts with it is, in the end, that we are all mutants, and so we all have mutations, and some will lead to a deformity. So that's very important to realize yourself. But if you want to know more about genetics, not only of the limbs but of the whole body, please read this. It's a very good. It's a very easy read, so it's very good to read on a holiday or a weekend or something like that. So this is a bit how our outpatient clinic goes. We see a lot of patients, but we try to make it very comfortable for them. So we try to have a chit chat. We are sometimes not, well, most of the time, probably I'm a type of a clown. And if you do your outpatient clinic, never be in a hurry, even if you are, because that then in that way, patients will feel that. There's also in adults, patients will feel that, and they will, and then it will take you longer, and you don't need that. You don't want that since you're in a hurry. Include caregivers and child. I've seen a lot of outpatient clinics for children, and a lot of doctors talk to the parents only, and but please include the kid as well. It gives them more comfort, and it's easier to have an examination. When we see them for the first time, we will do an examination from tip till toe, and we make it comfortable to them. So we have age-related conversations, and we've got age-related toys. And this boy built a big tower. This is our new hospital, just to let you know. So he built a special hospital for us. And actually, this type of play is toys is well, it's related to all ages, I guess, because I like to play with it as well. And be playful and be different, try to connect and know about PlayStation. At least that is what our kids, I don't know what your kids do, but they look television, they look at TikTok. So know what they're what in if they go to school, if they got a nice teacher, if they what they like to do after well, during the weekend, etc. So just have build a connection. And if you want to have them examined, but they don't like it, just in Dutch we call it spiegelen. So if you go and if they sit in a certain way, go and sit in a similar way, and it's a psychological thing, then the relationship is built. And so have them feel comfortable. And this is a bit what it looks like on the right, and on the left is not what my outpatient clinic look like, but what I would love to look like, as if it was in my just in your home, where everybody feels comfortable and goes and sit at the table. It should be fun. So we hardly touch children. We watch them during playing, and that is the real important part. Look at the child if you want to touch them. Just say it that you want to, and look at them and explain what you're going to do, and be honest. So if it's painful, or it might be painful, please say it and use positive words. And sometimes the children don't want to go home anymore because they want to play, and to our opinion, that is a compliment. So this is where you came for the congenital hands, but I think the first part is the start of it all, to have the connection with the kid and the parents. So we'll go from very easy things to more difficult things, and this is a polydactyly. It's obviously a polydactyly of the ulnar side of the finger, of the ulnar side of the hand. And I'm very curious who treats it in how do you treat it? So would you do, well, because probably you'll see it a lot. And do you treat it do you treat it, or does some other doctor treat it, and how? I can't see the reactions, by the way, so maybe Margriet can help me out a bit.
Sure. I'm seeing maybe people, I don't know if people can raise their hands in Zoom. I'm more used to Teams.
Yeah, me too. So that's why I'm
Yeah.
struggling as well.
Yeah. Well, I can give you the answer. For me, I surgically remove it, so I don't use clips
And
because
at
of
what age?
If it's before the age of 3 months, I do it under local anesthesia, and we let the parents give them breastfeeding or the bottle. And if it's older, also depends on the child. It's not extremely strict, the 3 months, but approximately 3 months. And if it's older, we wait until after the age of 1.
Yeah.
I don't know if anyone else would like to share if they have any other
Yeah, would be
experience.
great to share some thoughts on it because there's a very big difference in the whole world how to treat this. So
Is there anyone else who would like to elaborate on how they treat this?
I can say
Yes.
something if nobody else wants to say anything. I do something similar.
No, I would like to say something that here in Uganda, the small ones like that, like the one in the picture, the midwives actually tie them with a suture and then in a week time or so, they drop off. But the more complex ones are treated by us at around 3 months, from 3 months onwards, surgically.
and by the more complex ones, do you mean the one with a broader skin part or
Yes, the ones with a broader base, and
yeah,
also the ones which have bones and all those structures included.
as if it was a real little finger?
Finger.
Yeah,
Yes,
yeah.
yes, yes.
So
Yeah.
there was someone else who wanted to speak, to say something.
Christiane, I thought I would say something if nobody else was going to respond,
Yeah,
but I heard a nice reaction from Idris. My experience is if you tie them off, just to respond to Idris, is that you always have
yeah.
this.
Wait, Christian. I'll come to that.
Okay.
Yeah,
My experience is to do it as quickly as possible, and
yeah,
I surgically remove them. I'm
yeah,
not a big fan of tying them off, but you're
yeah,
going to tell them why.
yeah.
Okay.
So because I understand that, well, in the Netherlands, and I think in Europe and actually all over the world, it's often tied by midwives. And our experience with that is that you can imagine that if you have, can you see my hands or not?
Yes.
Yeah. So if you the base often is a very is can go from very small to a bit wider, and but is tailored somewhere in the middle or more at the base. And if you tie it, the knot or the rope will find the part with the smallest circumference. So in the end, if you tie it off at this area, you will have a tiny bum, as you can see on the a picture on the right in the middle where my cursor is right now. So and there and in at least in our experience, a lot of patients came to our hospital to have it removed surgically at a later phase. Furthermore, when I arrived in Rotterdam, and that's a long time ago, they used to operate it at an age of 1 year of age because then there was still the belief that it was the most safe way to operate it, and we didn't have the logistics to do it on the local. So when I arrived in Rotterdam, I tried to do it on the local because I was taught so in Leeds by congenital hand surgeon. However, we had nurses who were afraid, and if you have an afraid nurse, an afraid anesthesiologist, or the whole room, there's some scary thought of doing it on the local in a very young child. Then the child will be afraid as well. And moreover, all these tiny influences will have an impact later in life. So if you can have that as quick as possible and as dirty as possible, then the trauma for the child won't be that big as well. So when I visited Mary Beth Ezaki, I'm at work, so sometimes some people come in. Mary Beth Ezaki did the clipping method. So that actually is like the tying it with a rope. However, you put the clip directly to the finger. You can use pretty wide. You can do it in pretty wide bases because you've got larger clips, and it's quick and dirty. You can do it with or without anesthesia. The problem with anesthesia is that you have a painful prick or painful sting of the needle. And the disadvantage of doing it without anesthesia is that you have a painful setting of the clip. And so what we do is we do a little bit of EMLA. So it's an anesthesiologic cream. So it's less painful. And if we look at the results, they are in the middle of resection at an age of 1 to 1.5 years of age, and the tying off. And actually, we're doing this now for more than 15 years, and I think that we've seen 2 or 3 patients back who complained about the scar at the border of the little finger. So this is what we prefer because it's very quick and dirty on the outpatient clinic. You don't have to arrange anything else. You don't need an extensive preparation with, in the end, happy parents and a good result. So I think in the end, it depends a lot on the logistics in your hospital. Is this a bit what you wanted to say as well, Christianne?
I'll answer for him. Yes.
Yeah.
Can I ask you, Christiane, how
Yeah.
long does it take before it becomes necrotic, and what do you tell the parents about that process?
Well, we hope to see them as soon as possible. So we also do it before 3 months. Parents mostly already have experience with the umbilical cord. So I refer to the umbilical cord. It takes 8 to 14 days before it falls off, at least before the clips fall off. And what I do, I remove the little pinky because when it's getting necrotic, it might also be painful or give an inflammation of the true little finger. So that is what I changed in the treatment within a year. So I removed just cut the finger off and put it in a tiny little thing to give it to the parents if they want to. Yeah, I'm always afraid that the clips will be eaten by the child. So I advise to give them very tiny gloves for the days that the clips are still on, and if the clips are off, they can remove the gloves as well. And these are the anti-scratch gloves children often get when they are little.
Yeah. Okay.
So that's a little bit what I do with the little finger. Well, then there is. Are there any questions about and would that be suitable to do it in Uganda as well?
Well, it's as you say that it depends on the availability of what use. We don't have those clips here in Uganda, so we can only use a suture to do that kind of work. Yes, yes. Yeah, and we don't have that little glove he was talking about.
Yeah, I understand.
Yeah.
Yeah, then you have the risk of having the little numb on the index finger or on the little finger. Yeah.
Little finger, yes,
Yeah.
yes.
But probably, but please correct me if I'm wrong. I think you see it really a lot, and it's familiar, or not?
Yes, yes. It is one of the most common congenital malformations.
Yeah, so it is probably you don't mind that the that the nurse does it just because your outpatient clinic will be flooded by extra little pinkies.
Indeed, the only challenge is that sometimes they overdo it. They go for the bigger ones.
Yeah.
And then the child comes with necrosis, infection around the finger, and sometimes septicemia.
Yeah. And
yes.
Have you ever seen, because that's what I once had, is that they did this in a other hospital in the Netherlands, and it kept bleeding, and they weren't the parents weren't, well, they didn't believe the parents when the parents said it's bleeding a lot. And then they reached out to our hospital, and I saw them on the ER, and actually the kid was bleeding out because of an arterial bleeding of the surgical removal of the little finger, extra little finger. Did you have those cases? Did you?
Yeah, actually, I've handled about 2 cases like that, and we had even to transfuse the babies.
Yeah.
Because they came in with severe anemia.
Yeah. So
the bleeding and then we had to go to theater and do it surgically.
Yeah.
Stop the bleeding and close. Yes.
Yeah. So even if you think, and I think this is also a good point to take in mind, even though it's a very tiny thing that you believe it's a tiny thing just to remove it, because the children are very young.
It's freezing out. I don't know why.
Yeah, if the stitch isn't right in
some internet
way,
problem.
or they can just bleed out. So you always have to be aware. Yeah. So, then continuing to the other side of the hand, it's radial polydactyly. And this is also just to show you, because I've seen, we've discussed already the cases you discussed. We also discussed the extra thumb as well. But if you look at, and we all know the Wassel classification, there was a funny story about the Wassel classification. So actually we should call it the Iowa classification. But we've got, this is all type 4 extra thumbs, because they are at the MCP joint level, but you have to treat them all differently. So it's also very important to take in mind that it's not just to cut off the extra thumb as you do in those very tiny little fingers, but reconstruct the whole finger. This is the classification as we use it in Rotterdam. It's the Rotterdam classification for polydactyly, in which we also included the triplications, the triphalangeal thumbs, because we see a lot of triphalangeal thumbs from a certain part of the Netherlands. We also describe the hypoplastic or floating thumbs and the deviation in the thumb, because in the end, if you want to do research, and that is what it was for, it's very good to have all those splitting instead of lumping cases, just to be sure what you're talking about. And the example is 4 types 4 who need to be treated all in a different way. If you just look in an overview, this is completely to the left upper hand. It's radial polydactyly with, and you can see that you have to address to the bony part, because you don't have a straight or parallel joints of the CMC joint and the MCP joint in this case. And there is, in this case, also a deviation in the IP joint. So you have to address to the radial lateral ligament. You have to address to the position of the bone, of the metacarpal, and often also to the position of your IP joint. So you have to do an osteotomy of your basal phalanx. And in this drawing, there aren't any tendons drawn, but also these can be more to the and mostly you will spare the ulnar thumb, and the extensors and flexors mostly in these cases will insert at the radial side of the thumb, and during growth it might give a different pull, and therefore it grows crooked again. So it has to, you have to take care for a lot of that. And if you want to read about anatomy and anatomic changes in radial polydactyly, then the articles of Breed Crowley, you write it as Crowley. If you want to, I can put it later in the app group. And if you search for her, you will find a lot on the anatomy and polydactyly. It's very interesting to my mind. So this is where we do a reconstruction of the whole of two thumbs. So we make one thumb, good thumb out of two thumbs. It doesn't mean we do a billow cloquet, but what I mean is that we use the best bony part and skin and everything that is needed to make a good thumb is used from the thumb that we are going to discard. So this is actually one of the principalizations of plastic surgery. And you should never throw away something before you know you don't need it anymore. So if you look at this is, I hope everybody can see it, see my cursor. So this is the ulnar thumb, and here is the radial thumb. And these are connections between the two thumbs. So first, these are the extensors, and there is a bridging tendinous part that is connecting the extensor tendons. Then you see this part, and then you think that probably is a connection of the bone or another fibrous tissue, but actually it is the FPL, it's the flexor tendon. And so you always have to take care that where the bifurcations of the flexor tendon and the extensor tendon is. Otherwise, you might cut it and the patient won't be able to flex the thumb anymore after this discarding one. And a giveaway of a very distal bifurcation of the polydactyly, of the FPL, I mean, is a very distal syndactyly in type 4 polydactyly. So I hope everybody can follow me still. So you have to take that into account. And what I do is I'm very, I know in literature they have this, if it's a bit skewed, it's okay, you can just remove one. But I've seen too many patients with a Z deformity of the extra thumb on the long run who didn't have an osteotomy beforehand. So I'm very picky on that, and I want a straight thumb directly after the operation. So what I'll do, I will do a longitudinal osteotomy of the metacarpal head in a type 4 because it's way too broad. I just cut one part after saving the whole attachments of the muscles and then the radial collateral ligament, if necessary. And I think that in most cases, you need to do a closing wedge osteotomy of the metacarpal head to have it more straightened, so that so if this P1 is removed, you have to straighten that one. Then I connect everything again. And if it's connected and everything is straight, like this one, I put a K-wire in. So the K-wire in is not to put it straight, but to keep it straight during immobilization, and to have the osteotomies healed. One of the things that a lot of what I discovered a lot of children have is that they have a very distal insertion of the adductor of the thumb. So because it's more distal, it pulls to the ulnar side. So if you don't put in the K-wire, you might have a different healing of your osteotomy, but also the healing of your radial collateral ligament can be disturbed by that force on the ulnar side where the adductor pulls the thumb to the ulnar side. So that is one of the tips I would like to give you. And I didn't learn that. I discovered that the hard way, if you understand what I mean. So these are this one slipped with the Dutch part. I'm sorry, but we did a lot of research on this, and we discovered that the first operation is the most important one. So you have to be very picky, do it right in the first operation, because then you will have the best outcome on the long run. And if you do an operation, we had better results, and this was a multi-center trial. If you do it after they are 1 year of age, because they've got better results. We don't know exactly why, but that was one of the key points. And try to do it, what I said before, try to do it at once, because if you have to revise it later on, it won't be that functional or aesthetically pleasing as it is when you do it good in the first way, in your first operation. So these are operations that this is one of the congenital hand differences we see a lot in our region. And it might look simple, but in the end, every time I think it's the anatomy is different every time, and every time is very. I have a similar approach, but the things I do in every case are different, and it's very hard to get them perfect. And what is very important, the polydactyly often is associated with other syndromes. So it's important to be aware of that and to recognize that. And especially facial expressions are very important to learn for me as a congenital hand surgeon, because often in a lot of cases I know what the children what the deformity of the hand is just by looking at their face, because the face is often involved in the syndromes.
Christianne, can I ask you something?
Yeah, so this is the point, I guess, to have some questions on the radial polydactyly.
Oh, yeah. So I was wondering if you can tell us something. You were just talking about the flexor and the adductor. So do you see any differences in the extensor? Maybe interesting for people to hear.
Well, the similar thing on the extensor. So the extensor is positioned, or can be positioned also on not in a central way, but on the more on the radial side of the thumb you're going to keep. So you always have to check all the the pull of all the flexors and extensors and adjust it if necessary. Just to have a straight pull and a central pull during growth.
And how do you adjust it? Do you really loosen it and then reinsert it, or
it depends a little bit on where it is. So I like to when it's on one side, I like to loosen it and leave a little bit on the lateral side and then flip it. Do you understand what I mean? So like that. So there's still a connection, or sometimes just completely remove it and do reinsertion. And well, we can talk about reinsertions and techniques about that all day, I guess. And there are a lot of preferences, but these are similar as in flexor tendon injuries, I guess. And I don't like to pull through because you damage the nail, and just like to stitch it at the periosteum, because
Yeah.
children, the periosteum is very very thick, so you can use it to pull a stitch in.
Yep.
So that's how I do it. So I don't know if there are more questions or if this is a sufficient answer for you.
Yeah, sure. Thank you. For me, that was fine. I was just wondering if that's interesting to hear for others as well.
Yeah.
Anyone else a question about the radial polydactyly? Okay, so please move on.
Yeah, let's move on to the syndactyly. I don't know if you see that a lot. I think so. I can't remember a case even with a macrodactyly and a syndactyly. So
I see it a lot. I cannot answer for the other people, but
yeah, I'm asking for the
there's
Uganda
many.
people.
There's many.
I'm
So
not
many.
asking you, Margriet.
No.
Well, there are, with regard to syndactyly, I can talk about all the flaps that are used to reconstruct the first web, or the web, I mean, and to my opinion, it's very important to have and just these are cases we see with polydactyly, syndactyly, etc., and the triphalangeal thumb. So these are great cases to operate. But if you look at syndactyly, and you look at the complications you have, you've got short-term complications like infection, flap loss, and the full thickness skin graft loss. And the long complications are the web creeps, the scar contractures, and then keloids and hyperpigmentations of skin grafts, etc., and growing hair. And if so, what I believe is that if you know these long-term complications and the short-term complications, find a flap or technique that suits you and that doesn't give you these problems. And one of the what I well, infections I hardly see. I hardly see any flap loss nor full thickness skin graft loss. But that might be the reason, because I put them in a bandage for 6 weeks. So after 6 weeks, everything is healed. I learned that in Australia, and I thought that when they can send when it's in Australia where it's very hot and they have a bandage on for 6 weeks and it works, then it works in the Netherlands as well. So we did a evaluation and research on that as well, and actually they were better than the kids that had a bandage for 2 weeks and then removed, and then parents have to put the bandage on every day. That is really difficult for the parents to do. It's in an age range where you have to make a connection with your child, and the only thing you're doing is hurting the child. So I truly believe in putting it away for 6 weeks. I'm not curious. I trust my instinct with regard to the full thickness skin graft and just have it healed. And with regard to web creep, I think and scar contracture, there are two things that are very important, and I have to check the. So if you look at the web creep, it's the migration of the web more distal during growth, and actually the web doesn't creep, but the scar on the lateral sides of the finger have a certain length, and during growth, if the length isn't able to, or if that length is still similar, so if you've got a linear scar or hardly any Z-plasties, the length will be the same, but the finger will be longer. So actually the web doesn't creep, but the scar tissue pulls it more distal. And this is a way of evaluating that. And if I look at this picture, this is from an article. If I look at this picture, to my opinion, this is not a web creep. This is a secondarily healed desyndactylization with hypertrophic scarring. So this is, to my opinion, not a web creep. So if you look at in practice to the web creep or the complications, you can have a skin bridge between, I don't know if you've sometimes seen it. So this is a full thickness skin graft. This is a full thickness skin graft. This was the dorsal flap that actually runs below this scar. I don't know if you see this. So the two wounds of the fingers kissed each other and healed very nicely, but with a web that's more distal. And another thing I see in web creep is if you have scars in the web. So I use a flap in which a very big dorsal part of skin is put into the finger from dorsal to volar, and it also has a input on the volar side and not in the web itself. I don't know if you can see this, because I think that it gives a better result on the long run. And it says don't use a flap from dorsal to volar. Use a flap from dorsal to volar, to my opinion, and not from volar to dorsal, because the volar skin has less pigmentation, and if you put that less pigmentation to the dorsal side, then it will be very conspicuous, and people will see that there's something different to that hand, and it will bring attention to the hand. The reason for this skin bridging and these scars in the web is the technique, what I already explained, an infection and a secondary healing. So these are all causes you can prevent by choosing the right technique and the right bandage. So if you put a bandage on, don't put it loosely, but very tight, so there won't be any connection between the two fingers you separated. Well, if you see a case like this and patients want to have an improvement, and you can imagine that if you have a little bit of creep or it's very tight, like in this case, this movement is more difficult or even painful if the scar is in your web. What I do, I recreate the defects, and I do a complete flap repositioning and redistribute the skins longitudinally. And a lot of times you just don't need another full thickness skin graft. And in some cases, if the skin is okay but still too distal, I would do a double opposing Z-plasty. And if the scars are stable and supple, I don't mind the scars. I just draw the Z-plasty across the scars and use them as flaps. Who will have scar contractures, and that is also very good to take in mind, is, well, some patients will have infections. And I learned from a patient that had a very severe infection, and I was flabbergasted because I never saw it. And we did a bandage, we gave antibiotics, and nothing improved. And then I thought, well, I'm going can he have diabetes? Because we see a lot of infections in diabetes. And he appeared to have diabetes, and he was treated for it, and the scar and the wounds healed perfectly. So if you just, well, don't recognize it as a normal thing in your clinic, think of other reasons why wounds don't heal. And in this case, or in one of my cases, it was diabetes that wasn't discovered yet it was a 1.5-year-old. And some patients will have hypertrophic scars. These are especially the patients with an overgrowth syndrome or a macrodactyly. We discussed the macrodactyly before, and they during one of our meetings, and they show hypertrophic scars or even keloids more than other patients. So you have to tell the parents that as well, and I will show you one later on. Scar contractures in the synpolydactyly and in symbrachydactyly and the second and fourth web we see more often because the children themselves aren't able to extend the fingers in an intrinsic way. So they can flex and extend them, but the intrinsics don't work because they aren't developed properly or aren't developed at all because of the synpolydactyly or the symbrachydactyly. So they aren't able to force have an extensive force against the scars, and often you will have to operate on them again. So that's the picture of the photographs you see, and this is a kid with a polysynactyly. So I had an extra finger removed, and the intrinsics were not normally developed, and this is what he got later on. And we did a redo and splinting until he was fully grown, and then he didn't have any problems with it anymore. Well, any questions about that? Everybody's okay?
Yeah, I don't have any questions. Anybody else? Okay, maybe also time-wise, I think, I don't know how much you've left, but I think we should move on. Yeah.
So now I'll move on to the first web space, and this is the last one. I just would like to give some tips and tricks on treating the first web in an easy way. I hardly use any free flaps or posterior interosseous flaps or whatever. And it's suitable in arthrogrypotic patients and in hypoplastic thumb patients, or even in burn patients. I've got an example. So if you look at the thumb, the movement of the movement of the thumb forms the first web space, but on the other hand, the web space facilitates the movement of the thumb. So if you take into account what is necessary to have a good first web space, it's the skin, you need the adductor, you need the first dorsal interosseous, and everything that is mentioned. You need that to have a proper function of your first thumb. And what is often forgotten, for instance, in a hypoplastic thumb or a arthrogryposis, which have tight first webs as well, that if we make a wide web during the operation, you've got a very wide web, you put a flap in it or whatever, and after 3 months it's like that again. And it's just because you don't have the abduction of the thumb or opposition of the thumb to create that web. So if you want to treat the first web, you have to think of a lot of things. These are a couple of reasons why you can have a web contracture. this is, well, if you've got a web that's not sufficient, it's very difficult to have manipulation of larger and smaller objects, and you can't grasp wide objects. And in the end, it's the thumb that is opposing, and we are the only ones who can do that. It's very important to know the reason. So it can be congenital or an injury or other traumas. And this is a way to minimize contractures in general, not in congenital hands, but in general. And what I often see is people who have a thumb problem, or even in a wrist fracture, where they put the thumb like that, and then after 4 or 6 weeks they come out of the cast, and then the thumb is stuck like that, and they have to practice very hard to get it out of the hand again. So I prefer a cast that just keeps the web wide, because not everybody will move the thumb properly when the wrist is injured. So there's a lot of things to take care of, and if I do, for instance, a hypoplastic thumb with an FDS4 opposition plasty in a type 3A or a type 2 hypoplastic thumb, I will do a skin release, and I will release the palmar and the dorsal fascia and the adductor aponeurosis, and often the neurovascular bundles are there, especially on the volar side of the index finger. It's very superficial, and I mostly use a double opposing Z plasty to do a deepening of the web. So you have to be around there to make your flap. I release the involved muscles, and I do a joint capsule release as if necessary. So for the available flaps, you've got several flaps. I'm not going into them all. I'm in favor. I really like the double opposing Z plasty, and I like the not the kite flap, the Skinner flap. And I don't like the kite flap, because the kite flap is from the dorsal side of your index finger. And if you put it somewhere else, you have to put a skin graft on the dorsal side of your index finger. It can give adhesions to the extensor apparatus, and it might be painful because it's very thin skin. So I like the Skinner flap, and I will show you later on. So you need a lot of bicycles in your bicycle shed. I'm a cyclist, so it's always N+1. So I have a lot of flaps that you can use, and you can use it properly in every different case. So I will go, because of the time, to the double opposing Z plasty and a jumping man. I often call it the jumping jack. I don't know if any one of you is in sports, but the jumping jack is the one that you have to stand and do this with your arms and your legs. And I discovered that a lot of residents or students remember this. If you just do it like this, and you do the jumping jack, they will remember the way they have to draw the double opposing Z plasty with this little thing in it. And this is after the operation in a patient with a hypoplastic thumb with a double opposing Z plasty. So this is the end result, and the thumb is much wider. And I always look at where I do my C flap. So if the C flap I put always on the volar side, and A and E flap I put on the dorsal side. Because if you place them, if you do it differently, and you use the A and the E on the volar side, then they will be sutured to the dorsal side of your hand. And then again, you've got the palmar skin to the dorsal side, which is very conspicuous. So I always put a C on this one. So then you only have a little bit of volar skin to the dorsal side as a tip. Probably you know this. So this is, you can do a dorsal rotation advancement flap in widening of the web. I often do this in a very narrow flaps and narrow webs in Apert syndrome, in syndactyles of the true syndactyles of the first web. It's described by Bukuramko, and then you use a very large flap on the dorsal side of your hand, and in the web part there is this little flap extension, and I put a Z plus D in, and every time is different because they're not always like this. So and then by releasing this whole flap, you can rotate it to the first web and put it in here. And when you raise this part, please take care of all the veins. You really have to keep them. So you lift it and you dissect it and leave the veins intact. Otherwise, you will have a dead rotation advancement flap. And this is after the operation with a much wider web. And this is in a burn contracture. I did the same. So this is the tenodesis effect. You can see there's no difference between extension of the wrist or flexion of the wrist. So the index finger and the thumb actually remain at a similar position. And this is after the operation, where this is the large rotation advancement flap, and it's completely put in the first web. And the only thing I used is a full thickness skin graft on the dorsal side of the thumb. And I don't know if I don't have a long-term result, but in the end, the patient could completely open the hand and use the hand again, and the thumb and index finger again. This is one of my favorite flaps. Read the article by Mary Beth Ezaki. She, at least if you want to know a lot about congenital hand surgery, read articles of Mary Beth Ezaki. She writes them, to my opinion, perfectly, and she has great ideas. And she's retired now, but still. This is, it's called the index rotation flap, but Skinner described it a long time ago in a book, but a book you can't find anymore on internet, and on PubMed. And Mary Beth named it in the end the index rotation flap. And this is a flap which is very versatile. You can use it for a shortage of skin on the volar side of the thumb, but you can also use it as a widening of the web, and this is where I use it most, and especially in these cases. So this is a child with a Freeman-Sheldon. It's a arthrogryposis syndrome with hands like this at birth, and we splint them, and then they've got so it's an enormous improvement, but still with contractures of the webs and of the palmar skin, with deficient palmar radial abduction of the thumb, extension of the thumb, and extension of the fingers. So if you want to deal with this first web, and you have to deal with the thumb as well, and with the skin on the volar side of the thumb, so you have to do the whole lot. So what I did is, this is that Skinner flap, and I put it, so this is the flap, and I put it into on the volar side of the hand. And you see some drawings on the radial side of the MCP as well, and on the fingers as well, because I did type of desyndactylization I'm not going to bother you with. So this is the flap. It's turned into the palm. This is after stitching. There is a little bit of abundance of the skin here, and I will show you how I deal with that nowadays. This will just, well, this will, because of the movement, it will be okay. You see a much more widened web. There's no problem of blanching and skin shortage on the photo side of the thumb anymore. But what you also have to do, you have to bring a force to bring out the thumb. So I did a EPL rerouting. There are more techniques to do that. So I did a lot to this kit, and this is a result 1 year after. And this is a tiny modification of the skinner flap, not to have that bulkiness on the dorsal side directly after the operation. I use that with this, making this a little V. So I will put this in. So it's actually a kind of, I made a bilobed flap of it. So this part goes to the palmar side of the hand, and this goes into this part. And the advantage of that is you don't have any bulk anymore on the dorsal side, but you also have some extra tissue on the radial side of the index finger, so that the blood flow to the finger, so that the index arteries aren't pinched that much. That is one of the risks of using the skinner flap. This is drawing. We have to draw which arm we're going to operate. Most people would put an arrow. I think that's not fun, so I asked them what they want to have and just draw it. What about time?
I think it's 20 past 6.
Yeah, so we're way over it. Well,
Yeah.
all the first web also is for the hypoplastic thumb. Well, this obviously there's a difference between the types of hypoplastic thumbs. But if you look, for instance, at a case like this, you will need to do and actually that was the message for the hypoplastic thumbs. You have to do a web widening as well. Take care of the fascia of all the muscles, so of the interossi, of the adductor. Just cut them like that. Take care of your neurovascular structures that are running there, because that is one of because it has been like that for a long time. All the time, actually, the fascia is tight, and the only way to get it more wide is to have the fascia cut. The CMC joint in for instance, a hypoplastic thumb, but also in arthrokyphosis is not normal. So you probably it never made a circumduction, and it will never be able to do a proper circumduction, and will have some restrictions, especially when it's very hypoplastic. So then you can do the whole lot, but if your CMC joint is stiff, in any patient, by the way, you can do, and if it's stiff in this position, you won't be able to get it up there. So you should, to my opinion, you should take the CMC joint into account as well. Well, then I think we are at the end.
Okay, well, thank you very much. I think that was very interesting with a lot of tips and tricks. I don't know if there's anyone with a burning question. I think we have time for maybe 1 or 2 questions. Anyone? So I do have a question about the last part, the first web. So in my experience, some of the flaps that you named do give less space than I would sometimes like. So I tend to use the jumping man or the Skinner flap that you were talking about. But can you give us any tips or tricks on which one to choose when?
Well, obviously for the jumping jack or the jumping man, you already have a little bit of web. Otherwise, you can't.
Yeah.
You can't do a jumping man. And so if it's more tight, I get more to the skinner flap. And if the skinner flap is not possible because it's too tight, then I'll go to and the web is very distal, then I'll go to the rotation advancement flaps. And sometimes I will use a thinner flap, but I always stay close to the hand itself. So I don't like, for instance, if you have a very tight first web, to use a posterior interosseous flap. They look nice at the beginning, but and especially on the OR, it looks very nice because you can hold the thumb like that and the index finger like that. You put the flap in, and but then we go back to what I told before. It's the CMC joint and the ability to do an opposition and an abduction. And if the patient isn't able to do it like that, the thumb will do this in the end, and then you will have a flap that is up here somewhere. So you have a web, but it's with a very floppy, bulky flap in it that feels a bit like a hovercraft, like it's just floating above the hand instead of giving a tight grip. So in those cases, I'd rather do several flaps together with a bit of skin graft, because this is all very thin. So if you put a thick flap in the first web, I really don't like it.
Yeah, I agree. And do you give them a splint afterwards?
We splint them for a half a year or longer, depending on so for instance, the arthocraposes, they will get splints until they are fully grown.
Yeah.